So this is a summary of Module 1 of the MSUD, Medications for Substance and Opioid Use Disorders. This is required if you're going to apply for DEA as a provider. So I just want to share a little bit here, some notes from Module 1. So the definition of SUD is you have to have at least, this is from DSM-5, you have to have at least 2 of the following symptoms, and they have to be occurring within 12 months period. And you have to specify what substance the patient is on. You can't just say the polysubstance. And you have to specify the severity depending on the amount of symptoms they're exhibiting. So the minimum is 2 to diagnose over 12 months, but the severity, it tells you how many symptoms you have to have in order for it to be severe, moderate, or mild. And these are the symptoms. So there's a total of 11 here. Okay, and then a little bit about dopamine. Drugs and natural rewards all elevate dopamine. And when you repeatedly use the drug, you weaken the brain dopamine system. And dopamine, obviously, the release of dopamine give you the subjective feeling of pleasure, reward. If you keep using it, it overrides the impulse, and you will have discomfort when stopped, and it can dysregulate the executive function. Addiction is treated as a chronic disease, and there's so many factors that do affect addiction that I kind of pulled from that PowerPoint and listed here. Age of onset, obviously if you start early, young, it's more likely to develop SUD as an adult. And then there's all these other factors too. Anxiety, depression, low self-esteem, impulse control, habits formation, distressing circumstances, social relationships, isolation, mental illnesses, ADHD, conduct, PTSD, stress, trauma, abuse, having access, family history, genetics, media influence, peer pressure, and weak family bonds. But the good news is addiction can be treated and the brain can recover. There's also medical diagnosis associated with addiction, such as these, mostly chronic pain, obviously. Harmful effects of drugs, obviously, these are all the things that could go wrong. Harm reduction is when the patient is in the process of quitting, I guess, but it's not black and white. There has to be a gray zone first before someone just cold turkey quit. Not everyone can quit like that. So this harm reduction, what it helps is reducing the harm of, even if the patient is still using drugs, at least we're reducing the harm. So the route of administration can be changed to reduce harm. We advise them not to do it alone. Avoid mixing and do stagger use. Don't take all the drugs at once. This is really to avoid death. And of course, don't drive. Sterile syringes to be given to people with addiction. At least it prevents HCV while they're in the process of reducing their intake and hopefully quitting altogether. Naloxone kits and training people how to use it. This can save lives. Fentanyl test strips can save lives. And of course, overdose prevention centers. Integrated care is very important. That's when you add multiple ways all at the same time to help the patient. And what it means here is that you're going to incorporate CBT, psychotherapy, and you're going to use harm reduction technique, and you're going to have primary care get involved, and you're going to refer them to overdose. You do all of the above. Hopefully one of them will work. So don't just say, oh yeah, I'm already doing therapy for it, I'm good to go. No, it's about integrated care. That's the key here. This has proven to work way more than one technique at a time. And I think later on, this course will focus more in detail about the drugs for opiate addiction, but methadone, it provides full activation of opioid receptors. So when we give this to the patients, they don't crave opiates anymore. The BUP, I'm gonna mess it up. Buprenorphine, the BUP. This is a partial opiate agonist, so it's Suboxone. That's an example. And then you have these two. Don't confuse the names; they're very similar. Naltrexone. This is your the other name for it is Revia. This one is an opiate antagonist. It blocks opiate receptors, but it's used for long-term treatment of opiate abuse. It's not for emergency treatment. Naloxone, on the other hand, which is Narcan, this one is the one used as emergency reversal for opiate overdose. So I'm almost done with this module here. We did the integration. I know they have it. You can listen to it also, but I prefer reading on my own because when someone's talking, I get distracted. All right, so conclusion. Let's see. I'm trying to see what's the important things to pull from this PowerPoint. Okay. All right, so that's it for module 1. All right, cool. Moving along here, module 2. All right, so module 2 here, screening, assessment, initiation. Okay. So I guess they're gonna tell us a little bit about screening tools. Okay, cool. Work physical. Six mixed drinks. Jesus. Look here. He does not consider cannabis as a drug. That's interesting. Okay. Oh, you're not gonna tell me? I guess I gotta listen to the video. I think it'll help me figure out the screening tool to use for this guy. Stage of change. I don't know what that means, but we'll find out. I'm depressed, my belly hurts. 54-year-old female present follow-up hypertension. She previously saw different. Parotid hypertension has been difficult to manage despite numerous medication trial. Okay, she's a regular drinker, needs AA. Present now for regular follow-up hypertension, but with new concern of feeling depressed and abdominal pain. That's interesting. Becomes clear abdominal pain is gastritis from alcohol. She reported drinking has gotten out of hand and she needs to go to AA. First episode of depression lasted 3 months, started before alcohol problem. Then during the second episode, she began drinking more. So see how depression and alcohol abuse aggravate each other, pretty much. Because she's drinking to numb the emotions. Okay. So how would you screen assess a patient? Does the patient need brief intervention? What's the patient's current stage of change? What strategies would you use? What would be the best setting for her treatment? How could you do Okay, these are interesting questions. So anyway, screening and assessment. Screening tool is SBIRT. So motivational interviewing is a type of tool that's used during psychotherapy. And then we have the CAGE. You know this from nursing school. Okay, that's a lot of screening. Which one do I use? Extended tools. Okay, online tool, tobacco. This one has TAPS, so tobacco, alcohol, prescription medication, and other substance use. Okay, I like that. Extended substance assessment, diagnosis, diagnostic. Physical assessment. Okay. So I guess we're gonna kind of screening tools. I guess I'll get to these later because I'm not familiar with these so much. But I'm just trying to figure out what do I need to know. Like, I'm not gonna memorize all this, but you gotta learn how to use it as a tool. It's OCD's king. Okay, SBIRT. Okay, we're gonna look that up to see what it means. Brief tools. All right. Audit C. And the DAST. Okay, cool. DAST 10. Okay. Extended tools. This is, oh, these are shorter ones. Okay. This is more extended. The audit. I just, like, at least I want to be familiar with these. Craft. Assist. And then the online tool. I do like this online tool. It's kind of cool. Okay, so this is what they're talking about, and then we're gonna find out what's used for what, you know, more specifics. So screening, pre-intervention, referral to treatment. Oh, that's what SBIRT stands for. Okay, so screening, brief intervention, referral. Okay, all right. So that's interesting. Screening, brief intervention, referral to treatment. Makes sense because you do want to do something about it. Brief intervention, then refer to treatment. So you don't want to just be like, oh, let's just refer you. You know, we want to do something about it, even if it's a brief. Why is this so small? Oh, it's the fault. Anyway, alcohol drug screening. Okay. So just because someone is positive does not mean you just diagnose them with SUD. All it means is you gotta investigate further, or further evaluation. That's kind of important. So this is NIDA. So see here, NIDA right here. So it's telling us what it is. These are the questions to ask. Okay. So first you do NIDA and then NIDA assist. Okay. Positive, pre-screen. See, alcohol interact with all this And these are the medical conditions. All right, screening is audit. Okay, and cage. Okay. So there's audit, and then there's audit C. Okay. Screening. All right. Well, I'm not gonna really go through this because I'm not planning on memorizing all this. Because in practice, if you work in a clinic, all of these will be available. As you're doing your assessment, all of these will be available. This is your cage. Okay, so many screenings. Okay. Additional assessment. Of course, you also want to do mental health assessment and physical assessment when someone is probably abusing drugs or alcohol. Impaired control, physical. So this is kind of important, I guess. I wonder if it needs to be affecting your... Let me look it up really quick. 1 second. I'm going to look up DSM-5 and look it up myself right here. Okay, SUD. Yeah, I think there's other criteria, not just... where is it? This one, I think. Okay, that's too much. I want specifically SUD, not... Ooh, this book is extensive. Oh my god, it hurts my head. Okay. Blah, blah, blah. Anxiety, somatic. I think it is this one then. I don't know, I thought it was its own thing. Oh well. Okay, this one. So look, the 10 classes of drugs here that goes under substance-related addiction disorders are caffeine. Look at that. Cannabis, hallucinogens, inhalants, opiates, sedative, hypnotics, anxiolytics, stimulants, such as all of these. Stimulants, and then tobacco and other or unknown. Okay. Look at that. It also includes gambling because it is an addiction. Okay, anyway, how do you diagnose? Where is it? SUD, okay. Where is this? It's not what I'm trying to find here. Alcohol intoxication, okay. This is caffeine, oh my god. This is take forever to get to what I'm trying to look for. Okay, this is the other. All right. So where's the main one? Withdrawal. Where the hell is the... Are you serious? So it's like the first one, I guess? Ugh. I thought it has its own category called SUD, substance use disorder, and it has its own little section. Is that it? Nope, that's cannabis. I thought there was one for all of them, but whatever. I mean, I have caffeine addiction. Let's just start with that. Oops. Okay, alcohol withdrawal, alcohol intoxication. Jesus Christ. Alcohol use. I'm just trying to find out, to diagnose SUD, the criteria has to say that it's been affecting their life. Okay, so what is all this crap? Oh, look, so it can be just addiction, but it can be also addiction with a bunch of other things going on. All right. Essential features of the sort of... Okay, so I think these are the criteria then. Jesus, how many criteria you guys have? Ugh. Okay, so the first thing is impaired control. This is the first criteria grouping. The individual may take the substance in larger amounts or over longer periods than it was originally intended. Oh, are we going through these? Oh my God. Okay. They tried to stop, they couldn't stop. Great deal of time is spent in activities necessary to obtain the substance, use the substance recovered from the effect. Craving or strong desire or urge to use the substance. Recurrent substance use resulting in failure, fulfill major role, obligation. Okay, this is kind of important. So the recurrent substance use is resulting in a failure to fulfill a major role, obligation, such as work, school, or home. And then the continued use, despite having persistent or recurring social intervention, caused by, exacerbated by the effect of, okay. And then, so look, it is actually here, it's messing up your life pretty much. So if it does, then yes, it is a type of diagnosis. Okay, thank you. It's just too complicated. So what it's saying here is there's impaired control, which is written here somewhere. Okay, all right. So anyway, you get the idea. It's causing you social issues. It's causing you physical and psychological issues, and you're having physiological problems also, which is withdrawal and tolerance. So there's physical, psychological, and then there's physiological. Okay. So this is what you're going to ask when someone is saying they do use a certain substance, so it's like an assessment. These are the screenings, right? It's fine here. All right, assessment questions. So we're gonna ask these questions, right? We're gonna ask, oh, like when the font doesn't match. Primary substance, last use, frequency, amount used, route, age, when did you start, periods of abstinence. So here you're really asking all these questions so you can see if this patient fits the SUD SUD diagnostics. Okay, all of this is important because it tells me, has they tried to treat it before? What has they tried, and what worked and what didn't work, and what prior treatment, what other drug-related complications they have. These are important questions, and that's how you get to your diagnosis. So save this. All right. This is important, if they ever had overdose in the past, and how did they detox. Yeah, and what treatment did they get? And then the assessment now, the physical assessment is important because you're looking for a lot of, okay, watch this. Oops. You're looking for a lot of things that these people might have that they're not even aware of, you know. SUD. Substance use disorder. Assessment questions for patients with SUD. Okay. Gotta ask these questions. But here, you're gonna think about all these stuff. Okay. Oh my God, didn't show properly. So you're gonna get your vitals, of course. Now, BMI and weight is important because some people, they do too much drugs and then it messes up their weights, so they become malnourished, you know. So vital signs include BMI, because you're checking for, of course, blood pressure, heart rate, all that. Full vital signs. In fact, I'll do it by itself. Now the physical exam, you're going to do ENT, you're going to do cardiac, respiratory. This is your typical stuff, you know, GI, neuro. Of course, you got to do everything, like regular exam. But then now labs, that's important. You're going to do CBC, CMP. Liver function is important. Thyroid function is important. Pregnancy is important. Urine drug screen. UA, HIV, HCV, HBV, you know, all the alphabets, and STD screening as well. And then, of course, you're going to look for PPD. Whoops. Look for, check the heart. And PPD to look for rule out TB. That's why we're doing this. Okay. Which makes sense to me. So that's your little physical assessment. And then more here, watch. If they have alcohol, you're looking for cardiomyopathy. Hypertension is going to be a problem. Arrhythmia. They might get cancer in their GI system, gastritis, and then liver problems, pancreas, anemia, and thrombocytopenia as well. With opiates, you're looking for respiratory problems and, of course, infection, especially because of injections. And then the GI, they'll say they're constipated a lot because opiate makes you constipated. And you're going to notice amenorrhea, which means no periods in women, and testicular atrophy in males. Cannabis, you're worried about GI system, throwing up. Look at that, it can cause testicular cancer and of course tachycardia. When it comes to stimulants, you're mostly looking for cardiovascular because obviously it stimulates you. So you might end up with hypertension or tachycardia or all of these problems, including all of this. Okay. Tobacco, you're looking mostly hypertension, and of course you're looking for respiratory problems. Now, MSE, this is just your mental health exam, so I'm not going to go through this, but I am going to add it here, of course. Mental health exam, mental status exam. Yeah. And I'm going to add suicidal assessment. You want to make sure they're not suicidal. And of course, they have high rates of psychiatric comorbidity. It's kind of important. So you always want to assess for mental illness, obviously. Especially depression, bipolar anxiety, psychotic, ADHD, all these things, borderline. The two personality really is borderline and antisocial. These two can cause the addiction. And sometimes substance-induced symptoms or disorders. This is kind of important because sometimes we don't know, are the symptoms coming from your mental illness, or is it coming from the alcohol or the substance you're abusing? So in order to figure this out, you're going to ask them about periods of abstinence. This is important because you're going to ask them, how do they usually behave when they're not taking drugs, which tells me how they are now. And that way I figure out, is this their baseline, or are these symptoms happening because of the drugs? So substance-induced symptoms. Or the withdrawal, are they withdrawing right now? Is that why they're having these symptoms, I don't know, what do they mean by temporal? Okay, let me do this. Okay, what is temporal relationship with substance? How the timing is related to person's substance use. Okay. See, that's important. Yeah. So this helps me rule out okay, watch this. This is kind of important, actually. Because you're asking these questions here. You're asking, did the symptoms start after substance was used? Did they occur during intoxication? Did they occur during withdrawal? Or the symptom present before substance use? Did the symptoms appear when this person is abstinent? This is all important clarification. So There's, for example, substance-induced depression. That's when the patient is saying first they start using cocaine, then they developed depression shortly afterwards. And then when they're sober, depression goes away. So that means this depression is substance-induced. It's not that the patient's depressed. It's due to the substance. Okay, so that's what a temporal relationship is. Okay, it's kind of interesting, actually. I like this explanation. Means the depression the patient is having is substance-induced. When asked about said he starts using cocaine, felt depressed. Okay, depression improved after several weeks of sobriety. Okay, so that means this is temporal. Okay. Depression may be substance-induced rather than primary. It's not a primary primary diagnosis, major depressive disorder. It's not a primary diagnostic. Now watch this. This is a primary bipolar disorder. Patient had manic depressive episodes before ever using drugs. Symptoms continued even when they were sober, so it doesn't matter. So this temporal relationship suggests a primary bipolar disorder. Oh, so temporal is not really. Okay. I think I'll just leave it like that. It's getting confusing. Ugh. There. I think this is more. Yeah. I just like plain English more than, what is this? Temporal, blah, blah, blah. It's like, tell me, what do you try to say? Expected withdrawal. Okay. All right. Okay, so this is back to the assessment here. It's saying it says pre-intervention. Okay. So after you do your SBIRT, you're using that to screen. Okay, use the screen. All right. And then the intervention you're going to do afterwards is like a this is talking about the brief intervention. This is kind of interesting. Encourage reflection, talk about it a little bit. Okay, so SBIRT. That's just MI. Brief intervention is so this is like a little talking, reflection, non-judgmental. All right, and then watch this. Pre-contemplation, contemplation, preparation, action, maintenance, relapse. Okay, so engage, develop comfortable way to report. Frame discussion further. Sure, okay. This is way too many acronyms that I'm not going to remember. Of course, open-ended questions. All right. Perception. Patient perception is important because it helps me eventually know if they're really gonna quit or not, I guess. Because that kid that earlier they were talking about, that example sample case study, he's 19 or something, and he says he doesn't think cannabis is a drug, which tell me that's his perception. So that's kind of interesting perception, I guess. And then we're going to do identify personal values and goals. Why is this important? Because you will use this one day to show them that if that's the goal you're trying to get to, if that's your values, drugs are hindering you and stopping you from reaching your goals. Okay, there it is. Discuss the impact of substance on goals. Develop discrepancy between substance use and achieving goals. Elicit the need and perceive ability to change. Okay. You're going to tell them the risk, the consequences. You're going to express concern. You're going to support their self-determination. Autonomy. I like this one. So emphasize confidence and ability to change, especially if I share with them other people, like without HIPAA or anything, but just saying, hey, I helped a lot of patients before you. They actually stopped and their lives changed, Validate frustration. Okay, cool. And then make the goals. Meeting patient where they are. Make goals attainable and measurable and timely. Remember those. Follow up. and acknowledge their effort. Okay. So now so that was the brief intervention. Now we're in the treatment. So now we're going to do referral to treatment. So really the brief intervention is talking to the patient. So this is when you refer to all right. Interesting. So see what I mean? This is the harm reduction I was talking about. It's about social justice. Like, okay, if someone want to use drugs, you can't, like, it's illegal, obviously, but you can help. You can help instead of doing stigma and all that. So these are ways to help, I guess, reduce the harm at least so they don't die. What the hell is a snort? Oh, snort. Okay, I thought it said snot. Okay. Okay. So this is nice. I do like this table. Finally, an interesting table showed up. So this one here, wait a second, I thought, oh, this one stopped. Oh, okay. I thought this was for opiates. And this. Oh yeah, it's right here. Okay, so opiates is XR. Okay, this is kind of important. I do like this. All right, I need this information. So we're gonna go here, save this, and then you go to the drugs. Where's the medication? Okay, so watch this. It's a good start here, but I prefer to make it more. This is just like a general thing, but see what I mean? This one I wrote, this is for opiate, but naltrexone is also for alcohol. See what I mean? Whatever. So let's see. FDA approved medications. Okay, alcohol. It's gonna be oh gosh, I can never spell this right. Naltrexone. POIM. This is IM injection. This is a PO by mouth. All right, another one is acamprosate. Okay, this olphiram. See, I don't know that. Topiramate. This is off label. And gabapentin, believe it or not, off label. I wonder if we do this in telehealth. Can you do this in psych telehealth? Can you prescribe these things? I don't know. And of course, psychosocial treatment is important. So psychosocial okay. All right, SUD. Let's move this a little bit here. Okay, so of course we have CBT, relapse prevention therapy, motivational interviewing, motivational enhancement therapy, contingency management, 12-step facilities. We get AA, narcotics, marijuana, cocaine, and crystal meth. Who knew they have all of these for 12 steps? All right, so now back to the meds. Now this is for alcohol, and then we have opiates. This one is methadone and the pub that I mentioned earlier. Look at that. It can be either film, tablet, or subcutaneous. It's like under the tongue, yeah. Sublingual. Dissolve under the tongue. Or injection. Okay, look, no more. No more. Whatever that is. I've never seen that, so it doesn't matter. And then watch, you're going to also do naltrexone XR as an IM injection. See how this is interesting. I mean, they're not bad. This is not a bad list. I'm just saying naltrexone is used for both and alcohol. That's kind of nice. And then now tobacco. Watch tobacco. We got Vera. Oh my god, I'm so bad at these words. Can't see. Varin. And then you got your Wellbutrin, which we love, and nicotine. Replacement therapy. Get the patch, you get the gum, you get nasal spray, inhaler, lozenges. Cool. Okay, these are all FDA approved. So what's happening here? Why did you guys not fill out the stimulants in the cannabis? There's no FDA approved? I guess there's no FDA approved for these two or something. I don't know. Anywho. So this is good. I do like this one. All right, this is referral continuum. Yes, okay. All right. Okay. What's ASAM criteria? Guideline replacement, transfer, discharge for those with SUD. Okay. So this is the CWA patients. They're the ones who are inpatient. They're the one in the hospital. But this one is telling me the criteria, I guess. When do you admit patients? Is that what it is? It's for SUD, all of this. Where to place them, when to discharge. I don't know why I can't do my little thing today. It's time to eat. All right, guidelines for, okay, that's good to know. I'm not going to write all this down because, again, this is like a little cheat sheet. Continuum care model. Okay. So look here now, inpatient. So this is really where they can be, but in order for them to be inpatient, which means like a hospital, they should be having current intoxication, high risk of withdrawal, like their health is at risk here. They might die if they're not inpatient. They're having comorbid medical issues and comorbid psychiatric issues. Residential is not really acute intoxication. Low likelihood of withdrawal, requiring treatment, little or no active medical issues. But they do have constant supervision, okay? Now the partial one, no acute intoxication, daily supervision, okay. Intensive outpatient. What does this stand for? Again, I forgot. Kind of important. So anyway, this is the website, I guess. I need to save this website probably. I mean, one day I might need it, I don't know. But anyway, what does some Substance Abuse Mental Health Services Administration. Oh my God. SAMHSA. ChatGPT, write this down. I'm tired of writing things down. So what is it? U.S. Federal Agency within the U.S. Department of Health, Human... Oh, we promote mental health and treat, yeah, part of it. Okay, cool beans. Moving on. Where was I? Okay. Helpline. What's this? National Institute of Alcohol Abuse. An IAAA. Okay. All right, I'm here for my work physical. So back to our case studies. So this guy drank socially. He has 6 mixed drinks at the bar, and he doesn't think cannabis is a drug, and he smoke vaporizer or pen 1 to 2 nights per week. So you're going to ask open-ended, non-judgmental, patient-centered. These are the screens you're going to use. Oh, this was an interesting one. Who needs brief intervention and who need referral to treatment? Yeah, remember when it's okay, this is kind of important, I think. So if it's unhealthy use, you do brief intervention. If it's addiction, you use referral to treatment. Remember that slide. All right, pre-contemplation. Oh, the stage of change. Oh. I'm not really good at this too much, these words. Stages of change. I know there was pre-contemplation, contemplation. If you return with the inquiry, what should we do next? Indicative for this, you do diagnosis. Require referral. Alright, now this is the lady that's depressed. She has hypertension. She has depression, abdominal pain, gastritis from the alcohol. She's saying it's getting out of hand. She uses it to numb her emotion, and the spouse is a moderate drinker. So these are the screenings you're going to use. You're going to refer her to treatment. See, because she's not just, she said, I want to go to AA, so she's contemplation. Again, your interview strategies should have these information. And you do the criteria and to determine where is she going to be treated. Okay, so it determines where the patient should be treated. For her, you're going to do 12-step. You're going to consider medication and consider SSRI. Screening tool available, further assessment, important, brief intervention is important, treatment referral is important, and that's it. Okay, so I think the criteria is important. Let me just save it here somewhere. Where is it? Okay, so you're going to think about these things before you determine what am I doing with this patient. You can't send them home, but what am I going to do with them? Where are they going? So we got acute intoxication. See how vague this is? I don't like this. Yeah, would rather just look it up when it's time to use it. But what's important here is that we're determining where is the patient going to be treated. Is it going to be outpatient? Okay. Oops. Intensive outpatient. Partial hospitalized. Residential or inpatient. So that's why you need to use this tool to know. And the other thing also I was going to do was the stages of change. I think it's going to be important. I don't know. This one, contemplation, okay, preparation, action, maintenance. Action is important. Relapse, of course. Okay, that's it. So this was module 2 of the this one, MSUD, medications for substance use and opiate use disorders. So there's still module 3, 4, 5, 6, 7, 8, 9. All right, bye.